Hi, I'm going to talk a bit about ACL injuries. ACL injuries are very common. What is the ACL? It's termed the anterior cruciate ligament. It's one of the main ligaments in the middle of the knee responsible for stability. It controls front to back translation, but is also important with rotation. It's a young man's or young woman's injury, very common, but we really see it people of all ages now involved in athletic activities, but also in the workplace, sometimes with accidents. Typically it's involved with cutting and pivoting sports. Females overwhelmingly have much higher prevalence, 2 to 6 times that of males, for a variety of reasons, unfortunately. Specifically, our female basketball players and soccer players are particularly affected. It's really become an epidemic. The majority of injuries are non-contact, so patients landing from a jump, cutting, pivoting, change in direction, all can trigger the injury and lead to the pathology. Male injuries have a little bit higher incidence of contact in the sense of football, hockey, rugby, etc., where the foot's planted and they get hit, and that can also result in an ACL tear. The majority of these are treated surgically. We think that predictably most patients will not do well with an ACL, especially if they're involved in cutting, pivoting sports, but sometimes even just have an active lifestyle, an active job. Formerly, there seemed to be more age cutoffs with surgery, but that's really not the case anymore. We try to individualize ACL treatment and surgery to the patient. So someone who's older but quite active, either from a job standpoint or a hobby standpoint, including sports, we don't discriminate. So we want to get you back to your desired lifestyle if at all possible. Once the ACL is torn, it's torn, so it doesn't tend to heal. We don't think. There's some historical attempts at repair that were fraught with failure. There's some newer attempts at devising ACL repair surgery that is kind of in its infancy, showing some promise, but the gold standard is certainly what we call ACL reconstruction. That means to rebuild or reconstruct the ACL. It's typically done relatively early in the course to avoid re-injuries. We don't want the patients to feel better and get lulled into a false sense of security and going back to sport and sustaining a re-injury. Often with the injury, there's rapid swelling, loss of motion, trouble walking. That will tend to pass in most cases. And then sometimes the knee can be pretty normal and the patient can feel like, oh, I'm ready to go back. Well, we try to identify those patients early on and make the diagnosis and warn them so they don't have a re-injury. The concern with even the initial injury, but certain subsequent injuries, is any kind of tearing to the meniscus cartilage, which is a protector of the knee, as well as damaging the articular cartilage or the joint surface that kind of coats or lines the joint. Because again, once the ACL is torn, it's the subsequent injuries that can occur with repeat episodes that can maybe complicate the surgery or the recovery for the patient. ACL reconstruction typically involves either using an autograft or a graft or tendon from that patient, whether it's their quad tendon, their hamstring, or their patellar tendon. There's certainly allografts that can be used, but the results of allograft reconstruction in young patients is poor. The failure rate's 4 times that of autografts in patients under 25, so we tend to discourage that. Certainly for primary ACL reconstruction. It's done a little bit more in revisions when it's like a second or third surgery, which we don't like to think about, but it happens. Allografts can be used in older patients, the middle agers, like 40 and up, which is a rough guideline which can be modified depending on patient activity level, maybe perhaps any underlying problems or pathology they've had with their knee. Typically at the time of surgery, in addition to the reconstruction, we deal with any issues with the meniscus, either trimming the meniscus or repairing it, which is always our first goal. Also, smoothing down any articular cartilage damage and treating any other associated pathology to other ligaments, which isn't as frequent. After surgery, I use crutches typically for 3 to 4 weeks, although that sometimes can change up to 6 to 8 weeks, really dictated if there's any damage to the meniscus that needs to be protected while it's healing from a repair, or perhaps if there's an articular cartilage injury. I do use a brace post-operatively during the first 6 to 8 weeks on average, sometimes a little longer depending on, again, those meniscal surgery issues, or there's injuries to the other associated ligaments of the knee. In my protocol, patients can run after 3 months or at about 12 weeks if they don't have any other issues or meniscal repairs to protect. The back to sport is probably somewhere in the 6 to 8, 7 to 9 month range. We found increasingly the importance of not only time to get back to sport, but also looking at the patient, looking at their muscle, looking at their range of motion. Do they have any swelling? More importantly, we talk about return to sport or functional testing. And that's really an extension of therapy, which we use quite a bit throughout the early postoperative course. But the functional testing involves testing your quadriceps and hamstring strength and endurance against the well leg. We want that to be about 85 to 90% of normal. Similarly, there's some hop testing where you do some single leg hops for distance and time, as well as crossover hops. And then again, compare it to the well leg. We want that to be about 90% of the well leg. That seems to be indicative of a certain level of strength recovery and functional recovery for the patient, all designed to lower the re-injury risk. Lastly, there's a functional movement screen, which is done to kind of test the patient's balance and their reach on each leg in different directions, and it could be quantified and compared analytically for, again, reach that 90% threshold. There's good literature to suggest that patients who go back to sport without a strength test often are more predisposed to fail or re-injure their knee, especially if they return early. Patients who go through the design recovery protocol, go through the strength testing, and have a slow back to sport program and maybe wait that 6 to 8 months, have a much lower risk of getting hurt again. We can't make it a zero risk proposition, but we try to drive that down as low as possible and try to eliminate as many variables as we can. For those patients who don't want surgery or maybe aren't athletes, we can certainly try rehabilitation. Physical therapy can be helpful to get the pain and swelling down, get their range of motion back, and ultimately strengthen their knee to the point where they can resume daily activities. They may be able to walk or even straight line jog without issue. We are a little more cautious in allowing them to go back to cutting, pivoting, change of direction activities. Certainly there are functional braces that our athletes might use to go back to or go back to sport with. Alternatively, our industrial athletes working in the labor field may wear a brace. And lastly, patients who maybe opt for no surgery may want a brace for certain situations just for protection, such as going skiing or something like that. So we really try to individualize the treatment. Surgery is not for everybody, but certainly has a role for many of our patients.